please join me in warmly welcoming both Gabrielle and Martin.
First off, with this presentation, I'd like to tell you a little bit about the You in Mind service, quickly tell you about One Door Mental Health and share something about our services here, and then talk about how we're implementing You in Mind in this area. And then Martin will talk about You in Mind in Wallandilly and Wingecarribee. So how many have heard of us beforehand? Or Schizophrenia Fellowship? So a few of you know us. I'm glad the PHN, know us. Okay, so these are our services. So from Partners in Recovery, we have Jodie here. Jodie, stand up. Is she here? There she is, up the back. From Carer Services, we've got Janelle. She's probably still out on the stall. There she is, go and see her. We've got lots of nice stuff. With Respite Services, we've got some info brochures there. So if any of the carers want to break up at North Head at our sanctuary facility up there, carers and family can certainly go up there for a break. From support groups, we've got Sandra here from Beautiful Minds, who you'd all know. They're running their Waratah fundraising day on the 6th of October. Whereabouts, Sandra?
The Bankstown to Barrel.
Bankstown to Barrel, and selling Waratahs where?
Oh, in shopping centres at Bankstown, Liverpool and Campbelltown Hospital, but in shopping centres across that whole region, and we've got 4,000 of them and they're $5 each, so all the money will support mental health.
Thank you. Okay, we've also got centre-based services in at Bradbury and Barrel. We've got employment services, Headspace. Where's the Headspace team? We've got Vicky and Nina and Sylvia, who's a student there representing Headspace Campbelltown. NDIS support, we've got Nolene Charters, who's our area leader, who heads the whole team in Southwest Sydney. We've got education and training programs, so info out there, information and support. And the one that we're representing today is our healthcare service, and can I just introduce Jane Randall, who's our clinical director. So we've been running psychological and allied health services for about 9 years across Sydney. So it's a little bit about us and all our services. So now into You in Mind. So You in Mind is psychological services for underserviced population. So it's the ATAPS replacement program. So for people who can't access the current sort of health services with barriers to accessing Medicare services. So it's specifically, those underserviced populations are specifically called Aboriginal people and people living in Aids, Claymore, and the Miller postcode area 2168. And then also people in rural areas in Wallandilly, Wingecarribee. So you'll see a couple of other logos up there. Some of you might have heard Lynn and Jacinta from Community Connections, Emotions, Reflections. Okay, so they're providing Aboriginal services for Aboriginal people in Campbelltown, Camden, Wallandilly, Wingecarribee, and then Martin from Community Links and Wingecarribee Family Support Services will speak in a moment about their services down there. So One Door Mental Health is delivering services for called people, people in those nominated communities, and Aboriginal people in Bankstown, Liverpool, Fairfield. I guess you guys don't have to worry about who does what where, because there's one intake form for all of our services, and we have some wonderful intake clinicians. I don't know if you've met Stacey and Rhonda yet. Where are they? They're the intake clinicians who will sort all this out as to how you can access our services. Okay, so You in Mind is an evidence-based program. So these are all therapies that are approved by the Australian Psychological Society. So everything from cognitive behavioural therapy, family therapies, mindfulness, dialectic therapy, self-help, psycho-education. So the services that are delivered are all evidence-based, and all of the deliverers are, again, they're credentialed or registered allied mental health professionals. So we've got a lot of psychologists, registered clinical psychologists, credentialed mental health nurses, occupational therapists, mental health accredited social workers. We haven't got any Aboriginal health workers experienced in addressing mental health needs, but they are eligible to deliver the service. Okay, so what is different and unique about You in Mind? So it is different from ATAPS, and it has been redesigned through a co-design process. So some of you that were with the heard the Sector Connect presentation this morning talking about integrated mental health. They certainly spoke about a really extensive process that they went through in talking to the local community about what's working, what's not working, what do we need to do to really meet the mental health needs of the community that they're working with. So they've gone away, and the PHN have commissioned this new service, and this is some of the features of the new service. So for people who are in underserviced populations, no fees is a really important part of that. PHN Central Intake is a new feature, and that's really to ensure that people are getting the right service that they need. There's also greater flexibility in the service delivery. This is something that's really important. So, you know, we can take the service out into the community. People don't have to access it through a big banner sign that says, you know, Campbelltown Psychological sort of services that creates barriers. And there was recognition during the co-design process that people from underserviced populations just aren't accessing services in the way that other people might access services. Another really good part about this service is that some of it can be delivered by phone or Skype. So if people are feeling anxious and not wanting to come into the service, our clinicians can deliver the service, you know, over the phone and support people through that process. The delivery time that they get is 6 hours, and then they're eligible for another 6 hours. But also how you deliver the service is flexible. So if an initial visit with the clinician, it's going to take more time, you can take more time, and then you can do some shorter time as well. So it's not all fixed block, hour. It's, you know, responsive to the client's needs. It's from 12 years up, so you certainly heard the community connections, emotions, reflections, people talking about that, and also I think the Start the Kids spoke about that. One of the new parts about how do you get into the program, so GPs can refer into the program, but there's also identified referrers. So we've heard school counsellors mentioned as that. We've nominated the PIR team leaders to be identified referrers, and we're also talking to our community partners. And this is a really important sort of aspect of You in Mind, because we're working with these communities who are underserviced. They're generally communities with low levels of trust. So we're working with communities who already have that trusted relationship. So it makes sense that people who are trusted by those that can benefit from the service are referring them into the service. So that's a great way sort of to connect to these people who haven't missed out. You in Mind also has an ability to see people in distress, so you don't need that GP mental health plan, which has been sort of identified as a barrier for people accessing those services. So people, whether they come in with the identified referrers or as individuals in distress, after their initial assessment, the PHN has agreed that they can have another 2 assessments, so up to 3 hours in total before they get that GP mental health plan. And that's really in recognition that a lot of people can have problems in going to their GPs and you know, opening up about mental health issues. And as we've gone around and spoken to a number of the Migrant Resource Centre services, Arab Council and people like that, the stigma and the social identification of mental health is really a barrier to accessing the services. As I've been working with the PHN on these services, what's been great in when we've been talking about some of the boundary issues around who accesses what service, we've come back to a principle called client choice of the clinician. So in Lynn and Jacinta's service, that question sort of actually came up as well. Another thing that I really want to acknowledge with the new service is that it's a partnership. And from our perspective, in getting this new service up and running, the PHN has certainly demonstrated that it really is a partnership and working with us and working together. And certainly, 5 minutes. And certainly the sort of generosity from Stacey in Rhonda in offering to go out and explain to clinicians the new IT system, or you know, speaking with the PHN identified referrers, or Kristen talking about how do we do a brochure. And that's been really important because we recognise as a new service it's going to take a while for people out in the community, and particularly GPs, to get to know the service and to start referring into that service. So certainly that collaborative sort of nature that we're working with, we certainly sort of appreciate in that. Now, is it me? Oh, so it's going the wrong way. Okay, so for you in mind, these are our strategies in how we're providing our services. So we're targeting underserviced groups. So myself and Sandra, who's working with me with a hat on as a partnership coordinator, are going out and speaking to a lot of community organisations about the service and talking to them about how they can get involved. Whether that is them offering to put one of the psychologists in their service or referring people into the service. What's been really reassuring for me is the community organisations are just dead keen to get psychologists, you know, into their service, so that they can refer clients just to go in and see somebody without any big sort of barriers in going and seeing them. I've mentioned the issue about trust in the communities they're dealing with, and this comes up a lot with the core groups and the migrants and the new refugees sort of services that's coming up. Our approach also is about integrating our services, and so this is, I guess, particularly in those identified communities. So we've been out talking with Core Community Services, who's now running the Miller Hub. We've been speaking with Bujari, who's the Aboriginal Health Service next door, and catching up with the LHD on those type of things. So we're really looking at sort of, you know, just building that sort of cross-referral within those local communities. Because as people say to me, people in Miller just don't go into Liverpool to access health services with those ones. So with clinicians, so that's one of our strategies, is we're targeting the community organisations who work with the underserviced groups, but also equally it's the clinicians. We're currently contracting around 30 to 40 sort of clinicians to provide this service, but a lot of them are really busy. But what You in Mind is providing is an opportunity for them to actually build their business and build their practice. So we're wanting to work with them and identify which of those clinicians we can work more closely with to build our services. So certainly cultural sensitivity comes up as a big issue for all our community organisations when they talk about, you know, what do you want from a psychologist. So what we're doing, One Door Mental Health, is we're employing, so we've got a social worker, we're employing a psychologist to give us a bit more flexibility, and we're also subcontracting a whole range of psychologists and the other sort of clinicians as well. One of the things that we can offer under Jane's leadership is a community of practice for the clinicians that join us, so looking at getting them together around once a quarter to talk about how they're going with the service and introduce elements that will ensure continuous improvement. We were asked about future directions, and a lot of the community organisations are asking for Arabic-speaking clinicians, and whenever I find them, they're all booked out, so that's certainly a challenge. Aboriginal clinicians would be great. And I guess these are things that, as You in Mind rolls out, I'd like to sort of talk more about, is how do we as service providers help support more clinicians to get out there and deliver the services they need. So that's me, and I'm out. Oh, right on time. Hand over to Martin.
I've done this before. Thanks, Gabrielle. That was really clear. I hope you can emulate that.
There you go.
I have no slides. I'm going off a bit of a narrative here, and I'm hoping to drill down a little bit with what we've started over the last 9 weeks, specifically in Wallandilly and Wingecarribee. And hearing Professor Hickey talk this morning, I found inspiring, and I found it equally reassuring, because this is the kind of community development approach that we're taking across those two shires. And we have an eye on the short-term, medium-term, long-term kind of goals, up until obviously when funding's reviewed. So firstly, I was liking to thank the PHN for their support by way of practicing that which they ask of us: the reflection, creativity and innovation and responsiveness. So far, it's truly been a unity of shared vision and enthusiasm. So when I speak to the PHN staff, they're very supportive, and we kind of have a meeting of minds with our vision and our view and where we hope to go with the program. I'd like to start with a little bit of a metaphor that I've looked back and I've found myself repeatedly using to try to make sense of my time moving from Victoria into New South Wales, which, as we're all aware, is such a vast state. It has so many mental health services dotted around the place, and working inside community mental health for a period of time up here, I was often frustrated, confused, reassured, well-led, but I found myself constantly looking at the discharge process. And it kind of became clear to me that I was discharging a patient from care, whether it's somebody being discharged from a hospital inpatient unit, a GP practice, and it kind of felt like to me I was working with them, helping them kind of resolve symptoms and equipping people with a toolkit. And then we were kind of loading them into a small wooden boat and on the side of this vast ocean, unpredictable space, and kind of, I felt personally, pushing them out into this ocean. And I found myself waving on the shoreline, saying, goodbye, you know, I hope I don't see you again. And I'm not sure if it was something to do with hope or anxiety, but when the PHN put out this tender and I was invited to be part of a consortium to apply for this program, I jumped at the chance, because I see what is being created with you in mind as an opportunity to fill some of those gaps, albeit within some limitations around funding and 12 hours and staff on the ground. The Mental Health Commission have a vision that people will have the best opportunity for good mental health and well-being, and to live well in their community and on their own terms. The South West Sydney PHN are showing leadership in Wallandilly and Wingecarribee by supporting the creation of an innovative, flexible and accessible mental health service capable of reaching all cultures and communities across both shires. And to do so, You in Mind is building on existing relationships and networks in order to facilitate this. As the lead agent in the You in Mind consortium across Wingecarribee and Wallandilly, Community Links Wallandilly and Wingecarribee Family Support Services has broad expertise across local community support, and it's fair to say is a trusted and respected provider of client-focused care for all ages and cultures, making it perfectly positioned to implement clinical psychological services for people living with mild to moderate mental health issues. The consortium is made up of multidisciplinary allied health clinicians who all share a wide range of evidence-based practice. An important part of this is our information manager, Karen May, who comes from a different background, but she's largely responsible for holding the intake list and organising the information and management of that information on a local level. Looking at the key indicators of reform, we can create a scaffolding that allows a structure by way of key tasks. These indicators aim to increase positive mental health and well-being, participation by people with a mental illness, the peer workforce, positive experience of service delivery, the proportion of New South Wales mental health funding to be spent on community-based services, and will decrease psychological distress in the community, discrimination and stigma, suicide and suicidal behaviour, the use of involuntary treatment orders, and the proportion of people in prison population who have a mental illness. In Wallandilly and Wingecarribee, we've been building on pre-existing relationships with GPs, health services, not-for-profit organisations and schools, for the purpose of creating a familiarity between the service and referrers to provide troubleshooting, secondary consultation, spread of mental health information and awareness across all systems, and overall enhance consumer service provision. The Community Links Wallandilly and Wingecarribee Family Support Service relationships with these people have been vital, as they're a trusted and respected agency, enabling us to broker all manner of resourcing matters, such as shared spaces and information sharing. So in the last 8 weeks, part of my role has been driving into the outlying villages and seeking resources, our pre-existing resources, such as GP medical clinics, neighbourhood centres, church halls and so forth. Within the first 4 weeks, we met with the GPs and the practice manager at Robertson Medical Clinic, for example, and they offered us the space that they have to use for groups after hours. So we're banking on resources that we can go back to use at a later stage once we've established consistent themes from the outlying villages and a number of populations. The other one was Hilltop Schools, so we were able to broker an agreement with the principal of Hilltop Primary School, where we know, after interviewing and meeting with the GP practice there, that there's a vast number of mild to moderate presentations, people that have to travel into the service centres of Bowral and Tarmor that aren't necessarily equipped to go into those centres. So in conjunction with the Hilltop principal, Mark somebody, who was a lovely fella, Mark Gardner, the GP clinic, the practice manager at the GP practice at Hilltop, we've created a space that we're going to lease from the Hilltop Primary School in which we can insert clinicians, and the school are very interested because they want a stronger presence in their local community. So that kind of example, like hand and glove approach. And we'd also ideally like to build into the Hilltop GP practice, because currently they have no permanent psychological service embedded in their clinic. They're seeing thousands of people over a period of 4 weeks. So at some point we'll drill down over the next few months on the themes that are presenting, but at this stage, as most of us are probably aware, mostly it's acute anxiety, fleeting self-harm, suicidal expression and chronic depression. Outside of current community links and Wingecarribee family support managers and consortium clinicians, we aim to enhance responsiveness by way of efficiency and clarity. My role is to provide continual interfacing across community services and recruit local clinicians to join us as subcontractors and support them in their important function within the local community. Doing so by providing supervision and community liaison, as an example. One goal we have is to build a service that doesn't simply recreate the previous system, to which there are multiple levels. We look to build within Community Links and Wingecarribee Family Support Service programs, while also working alongside others, and ensure we build into these outlying villages. For example, Bundanoon, where we have a clinician lined up to do a couple of days consultation out in the clinic. We have people based at Mossvale, and I'll be the person out at Hilltop, at least initially. Also being very active in the last couple of months, building on some relationships and creating new relationships. One significantly was Centrelink at Bowral. So meeting with the social worker Sarah in there, sharing resources with her and creating a bit of a template about what we could potentially, how we could potentially work alongside in their office there. So obviously there's there's significant population of our cohort that would be going to Centrelink. So she will call me when there's a potential referral, but also I might be able to pop down and do a single session, which I'll get to later. We also have responsibility to provide group intervention, which is a really important innovation. We need to create new groups, so I'm waiting for feedback on the groups, but I've also been brokering relationships with people who have already had long-standing groups, one in Bowral and Mossvale, and another one grandparents of their grandchildren. So grandparents who have become parents again, that's a pre-existing group at Tarmore. So I've had to walk and create respectful relationships within those groups. And both of those groups now have agreed to create a purpose and a new agenda, and they're all getting themselves on mental health treatment plans because they want to grow the numbers of the group participants, they want to increase the frequency, and they want to grow it across the outlying villages. Non-GP referrals are also an innovation and will enhance our capacity to work within referral populations and access more people while creating and maintaining much needed relationships across different levels. Recently we had a little bit of media exposure in a local news outlet in the Southern Highland News, which headlined "Funds Boost for Mental Health." So we're pretty happy about that. I think she's going to do a follow-up interview with that, drilling down to what we're providing. In my role, I'll continually work at building up and sustaining referral pathways locally, and over time hope to establish a predictable mental health service which can potentially help structure the access issues across both rural communities, and maybe provide local clinicians with a regular network in which knowledge can be shared and relationships consolidated. In the context of some new information that suggests traditional models of treatment aren't necessarily adequate for some cohorts, I envisage a mental health service that addresses some long-standing issues of isolation, stigma, resistance, and one that values community participation at its heart. Thanks.